Today, we're getting under the hood of women's health with Dr. Shieva Ghofrany, a board-certified OBGYN practicing for over 25 years. She has used her own personal experiences as a patient with endometriosis, pregnancy loss, weight loss surgery, and ultimately ovarian cancer to help her really understand women and how we think about our health. She is the co-founder of Tribe Called V, a platform to help women learn about all of the OBGYN health issues they were never taught. Dr. Shieva is getting under the hood of high-risk pregnancy.
I'm an OBGYN, which is the acronym for obstetrician gynecologist. An obstetrician is actually the person who takes care of people who are pregnant and are having babies. And the gynecologist is the person who takes care of all of the other aspects of pelvic health and reproductive health, we refer to it as. But it's really everything having to do with a woman in many ways. And I chose it because it is a great mix of surgery, which I love to do, and still getting to be a primary care doctor to your patients and engage with them. There's a term, high-risk pregnancy, which I actually don't love using, mostly because I think it really inflicts a lot of fear in people who are pregnant and women, because they think that means that they are at high risk of something bad happening, when in reality, it merely means you have certain issues that we have to address differently. Nonetheless, it is an issue. It is a term that people use. And I think it's valuable for everyone to know that when you hear of a high-risk OB, that's equivalent to saying perinatologist and equivalent to saying maternal fetal medicine or MFM doctor. And they are specialists who do regular OBGYN training for 4 years and then an extra 3 years. And I want everyone to know that because they'll hear those terms. So typical things that we might consider higher risk than the norm would be a history of high blood pressure, a history of diabetes, twin pregnancies, if you are very young or come from a population that might be underserved with regard to your socioeconomics or your insurance, or if you are on the older side, which nowadays we have many people who are getting pregnant far older than 35, but that also poses certain concerns. So again, I don't love to say risk because that seems so scary, but I like to stratify with each patient. What are the things that we need to address in your particular case that we might need to do extra testing for? Each individual issue may change how we approach the pregnancy, meaning we may need to offer more tests depending on what significant issue a person has. We may need to change the route of delivery. So for example, let's take high blood pressure, which is increasingly common in our world. So we see patients who come into the pregnancy with hypertension or what we call high blood pressure, and what we call chronic hypertension because they're coming into the pregnancy already with that diagnosis, versus people who get diagnosed with preeclampsia, which is a version of high blood pressure in pregnancy, and that might occur in the middle or at the end of pregnancy. For example, if they come into it with hypertension, we have to see them more frequently to make sure their blood pressure doesn't go up. We have to monitor the baby differently because sometimes that baby ends up not getting the same amount of blood supply through the placenta and may end up being smaller in a way that can affect that particular child. We need to make sure that the patients, all the other aspects of their blood pressure, like swelling, headaches, is really ferreted out so they know what risks to look for. So it really just means that each individual patient might have a different set of tests or restrictions that they need to guide themselves with. When it comes to various risk factors, again, sometimes the delivery can be impacted, sometimes not. If we use blood pressure as an example, it really may or may not affect your delivery. You are absolutely able to have a vaginal birth, even with high blood pressure, even with what we call preeclampsia with severe features, which is an extreme version of that high blood pressure. But there might be times during labor where your blood pressure is so hard to control that we need to switch gears, get the baby out quickly, and reverse the syndrome that is happening and do a cesarean section. When it comes, for example, to twins, which are another situation where we watch patients more carefully, some twins are able to come out vaginally and others have to be a cesarean birth. So again, there's really no blanket statement. There are certain times where every single patient would absolutely need a cesarean section. For example, a placenta previa, where the placenta can be sitting on top of the cervix. I would venture to say that no one in the entire world would try to deliver a patient vaginally with a placenta previa. But that's one of the few absolutes that we have when it comes to what kind of delivery you would need. There are many pre-existing conditions that increase the risk during pregnancy. And unfortunately, the ones that we see the most seem to be increasing in our populations as well. As we know, as a population, we're actually getting heavier. And I say that very sensitively as someone who had 2 out of my 3 pregnancies. I was about 250 pounds, and that posed risks for me. So with the higher weight, we also have higher chances of high blood pressure, and we have higher chances of diabetes. And all of those actually can increase the need for a C-section, which can be absolutely life-saving and very, very safe. But many people would like to try vaginal birth, and that can be harder with increasing weight, high blood pressure, and diabetes. So those are the 3 most common ones that I would say we are seeing on the rise, and we are seeing increasingly cause other aspects to pregnancy that we need to address differently. We're also seeing a lot of people get pregnant at much older ages. And on one hand, that's wonderful for society and for our maturity and for our ability to prolong our careers. But it also poses a certain number of risks because as we age, our chance of high blood pressure and diabetes and our weight tend to all go up with that. So those are the most common things that we really address with time. It's really interesting because when people say to me as their doctor, am I a high risk pregnancy? I really try to dissuade them, as we talked about at the beginning, about using the term I'm a high risk pregnancy, because I think that just conveys this level of anxiety and fear that isn't necessary. But I think each individual patient deserves that discussion with their doctor. For example, if you are over 40, we know that even the healthiest, leanest, no diabetes, no high blood pressure patient over 40, in theory, has slightly higher chance that their placenta might not feed the baby as much as we need. And so the recommendation is that they would be induced or delivered at 40 weeks instead of letting them go up to a week past their due date. It's not a hard, fast rule that you have to, but all the guidelines allow for it and encourage it. Or in the olden days, we used to say if you were over 35, where your risk of Down syndrome was higher than your risk of having a miscarriage from the tests that we would do for Down syndrome, then we would discuss why we should stratify those tests for you. The good news is nowadays we have very good blood tests that kind of replace that amniocentesis, the older test that caused the potential risk for miscarriage. And so that blood test now is offered to everyone. You could be an 18-year-old with a very low risk for Down syndrome, but you deserve the right to know whether or not your baby has Down syndrome, if that's information you want. So now we've really changed certain things that we used to consider high-risk pregnancies as far as what tests we offer. That said, there is still an actual code in our diagnoses, the way we actually have to bill things for insurance with regard to people being over 35. And that code is called advanced maternal age. And with advanced maternal age, in theory, you may be offered more ultrasounds because your baby may theoretically not grow as much. You may be offered an induction earlier. The irony is that nowadays, I feel like so many of our patients, I don't want to say the majority, but it's reaching the majority of our patients are over 35 when they are planning their pregnancies. But so again, there are a list of many different things. Twins, for example, we have to do ultrasounds for twins much more frequently because when there are 2 babies growing in one uterus, there is the potential that one ends up taking a little bit more of the blood supply from the placentas than the other one. So that's just one example of times where we really need to pay more attention. It doesn't necessarily affect how you birth because it really depends on why you are considered at risk of anything. In other words, if you have, like we've talked about, high blood pressure or diabetes, you absolutely can try to deliver vaginally, but there may be times where we have to shift gears. If your blood pressure is out of control during labor, you may need that delivery to happen more expeditiously, and that would be by C-section. If you are diabetic, where we know that sometimes high glucose levels lead to bigger babies, you might need to have a C-section because we're worried that the size of that baby, especially if the baby is over 4,500 grams, which is about 10 pounds, that might be more dangerous for you to try vaginally. If you have twins and one or both of those twins is either breech, where their bottom is down, or sideways, that might be more challenging or almost impossible for the baby to come out vaginally. So again, there may be times where you are offered a C-section over a vaginal birth, and you certainly have the option because of bodily autonomy to make that decision on your own and talk to your doctor and your midwives about it. But there are very few hard, fast rules with regard to how it's going to affect the delivery. And I never want people to think that because of their potential risk issue, they have to have one birth over the other. I really try to encourage them to approach it openly, where they recognize there are pros and cons to both types of deliveries. And we really shouldn't have this binary where one is much better than the other, because that's what makes people feel very sad and very wedded to, for example, only a vaginal birth, and potentially lead to more risk because they push the limits as to what they should be doing. So one aspect that's really valuable for people to know during their pregnancy is most patients during pregnancy will be followed and taken care of by either their OBGYN or a midwife, or together an OBGYN with a midwife. There are times, depending on the risk issues that arise, either as the patient comes into the pregnancy or that arise during the pregnancy, that would require the general OBGYN, someone like me who's done 4 years of OBGYN training for residency. I might need to accept help and consign help from what we call the maternal fetal medicine doctor or the high risk specialist. And they help us strategize, what are we going to do during this pregnancy? How are we going to treat this patient? What tests do we need to offer? And is a vaginal birth something that we can still encourage and try, or is a cesarean section something that we need to schedule? Then during that potential vaginal birth, we also have to manage things differently. And we need to have the entire team understand, meaning the doctors, the nurses, anesthesia who may be involved. So one aspect that's important is for your doctor to help you know, are you able to deliver, for example, in the particular hospital that that doctor typically delivers their babies at? Certain hospitals, unfortunately, don't have 24/7 anesthesia available, which means that if they are trying a vaginal birth after a C-section, for example, or certain risk issues like a placenta previa, where the placenta is in front of the cervix, those are patients that they may refer to a different hospital where they have a more robust team for emergencies. That's not to say that every single pregnancy is at such high risk that you have to be in a hospital where everything is available, because most pregnancies really will progress and the labor will be okay to be in a smaller hospital, potentially a rural hospital, even birthing centers that are sometimes separate from the hospital, but have a connection where they can very quickly get into those hospitals. So again, I know I keep saying there's no one right answer, but it's really hard to make an answer that will fit everyone. And that's something that I want everyone to realize, that that's in a way the beauty of it. There's no blanket statement. I don't want everyone to hear what their mother, their sister, their best friends went through and think it's necessarily going to affect them. But I want them to hear all of these stories so that we can really realize that each person can be individual. But that's why it's very important to find a doctor or a midwife that you really trust, that you can collaborate with. I would encourage every person who is going to get pregnant to ideally, and I'm going to stress ideally, because we all live in the world where it's not ideal and many pregnancies are unplanned, even if they end up being desired. But ideally, you would be in physical shape that is commensurate with your lifestyle, meaning you are able to exercise to a degree, keep your weight in the leanest amount you can. I dislike the word BMI. I don't want to say a specific number for any given person, but we all know when we are exercising, when we are actually able to eat nutritiously, because that will actually set you up for a much healthier pregnancy. That will decrease the chance of diabetes, hypertension, that your weight is actually going to excessively go up during your pregnancy, which increases certain risks. So those are things that are really valuable, but not easy. Other things that we really need to stress are decreasing your alcohol intake, trying to stop smoking if you're smoking ahead of time, and then going into pregnancy. Again, the ideal would be trying to stay active, trying to exercise 3 to 5 days a week, trying to make sure you get a good amount of sleep every night, at least 7 to 8 hours. I keep stressing ideal because I think there's a lot of pressure on women, and it's a little unfair to be saying you need to do this to keep you and your baby healthy and happy, when that pressure and anxiety is something that is only going to add more stress, when in reality, many of us are living in a world, whether we're coming from a place of privilege or not, where we don't have either time or access to be able to do all these things. So there's ideal, and then there's realistic. So part of this, I would say, is forgiving yourself for not being able to do everything perfectly. But again, if you look at the list would be in as good a shape as you can be, make sure you're exercising, stop smoking, stop drinking, take a prenatal vitamin that has folic acid in it, and then continue all of those things during your pregnancy. I would give every person, every pregnant woman, whether or not she's high risk or non-high risk, my best advice would be you have to find and I will use the word provider here, meaning a doctor or a midwife that you really trust, that you can bond and collaborate with. Because if you go into that pregnancy, whether it's normal risk or high risk, and you do not feel a sense of trust in that doctor and understand that doctor's practice, you need to know who else is she in practice with, and will you be meeting them all, and who will be at your delivery. If you don't go into it with trust, then no matter how easy things are, you're not going to have as beautiful an experience. And if things get challenging, you are going to not feel as safe and validated and collaborated with. So the single best piece of advice I can give people would be, please find a doctor or midwife that you absolutely trust and feel collaborated with. If you're high risk, the odds are you're not going to be with a midwife only, because there are risk issues that doctors really need to be handling in this case. But sometimes that arises during your pregnancy, and your midwife will be able to co-manage with a high risk doctor or a regular OBGYN.